Good morning. I'm Jim Lando, the Regional Health Administrator for Region 5 in the Office of the Assistant Secretary for Health of the U.S. Department of Health and Human Services. On behalf of the Office of the Assistant Secretary for Health and the Office on Women's Health, I'd like to welcome everyone here in person in Columbus at The Ohio State University, as well as the thousands of webcast participants across the country. Welcome also to those of you who are viewing this through the archived recording. I would like to acknowledge our federal partners, the Substance Abuse and Mental Health Services Administration, SAMHSA, and HRSA, the Health Resources and Services Administration. I'd also like to thank Dr. William Martin, the Dean of the College of Public Health at the Ohio State University, for graciously hosting this event. We are very grateful for your collaboration and generosity. Dr. Martin will now provide some welcoming and framing remarks. Dr. Martin?
Thank you, Captain Lando. The College of Public Health and the Ohio State University welcomes you, the Department of Health and Human Services, as well as the panel of experts. The topic of healthier pregnancies and the use of the Affordable Care Act to initiate new preventive services for healthcare providers is incredibly timely, and in the context of Ohio, this is a great venue. Implicit in healthier pregnancies is a commitment to healthier babies. Ohio, according to the Centers for Disease Control and Prevention, currently ranks 46th out of 50 states in infant mortality. And more stunning is the recent statistic that we ranked 50th of 50 states in infant mortality for African American babies. So we are very attentive to what you're saying today. It is important for healthcare providers nationally, but particularly in Ohio, to learn about these preventive strategies and to implement them. On the other hand, infant mortality is not simply a healthcare delivery problem. It is a societal problem. This affects all of us. So thank you for joining us today at the Ohio Union in Columbus, Ohio. And we welcome this, and we're looking forward to the presentation.
Thank you, Dr. Martin. In 2011 and 2012, 71 million Americans with private health insurance gained access to preventive services through the Affordable Care Act. The Affordable Care Act makes prevention affordable and accessible for all Americans by requiring most health plans to cover and eliminate cost sharing for preventive services recommended by the U.S. Preventive Services Task Force. The Affordable Care Act makes women's health a priority by expanding access to preventive care. Recognizing that women are more likely to need preventive health services, but often have less ability to pay for these services, the Department of Health and Human Services adopted new guidelines for women's preventive services. These guidelines allowed 47 million women to gain guaranteed access to additional preventive services without paying more at the doctor's office, in addition to coverage for an annual well-woman preventive care visit. Today, we will address 6 of these U.S. Preventive Services recommendations and provide guidance on how they can successfully and efficiently be integrated into provider practice, with a particular focus on pregnant and newly delivered women. The specific preventive services to be addressed have a rating of either A or B from the U.S. Preventive Services Task Force, are covered at no cost under the Affordable Care Act, have an intersection of behavioral and physical health, and are particularly relevant to women during this stage of life. These experts will briefly touch on the science, but will focus largely on models of care regarding the following recommended services: tobacco use counseling, alcohol misuse screening and behavioral counseling, depression screening, intimate partner violence screening, obesity screening, and interventions to promote breastfeeding. We will also briefly present the basic principles of trauma-informed care, recognizing that in order to effectively help someone modify their behavior, you must understand what role that behavior has in their lives. This session is designed for clinicians, specifically those who care for pregnant and newly delivered women. We know your time is very valuable, and as such, these presentations will be fast-paced and focused on essential elements of what you need to know and consider to effectively provide these specific screenings, brief interventions, and referrals to counseling for your patients. We believe you will leave here wanting more detail and specifics. Accordingly, we've recorded longer, more in-depth presentations by each expert to drill down into finer details of effectively providing these services, as well as clinical vignettes for demonstrations. These interviews and vignettes will be available starting next week on the website on which you registered for this session. We are most grateful to our presenters not only for their commitment to providing exceptional care to their patients, but for the enormous amount of work that has gone into preparing their presentations, both what you will hear now as well as the recorded interviews. Not surprisingly, these presenters have impressive and very lengthy credentials. Instead of taking time to review their many accomplishments, I refer you to their bios provided for you in your folders and on the website. You'll hear from the following experts introduced in order of their presentations: Dr. Sheila Raja of the University of Illinois at Chicago, Dr. Sharon Phelan of the University of New Mexico, Dr. Mark Loafman of Northwestern University, Dr. Kate Menard of the University of North Carolina, Dr. Therese Zink of Wright State University, right here in Ohio, and last but not least, oh no, one more, Dr. Maureen Phipps of Brown University, and last but not least, Dr. Ann Borders of the University of Chicago. It now gives me great pleasure to present Dr. Sheila Raja to talk about trauma-informed care. Dr. Raja.
Thank you so much. I'm delighted to be here and talk about this very important issue today. I am going to talk about trauma-informed care and healthy pregnancy, what providers need to know in about 10 minutes or less. There is a longer archived version of this online for people who want more detail. So, what is trauma? You know, there are, of course, mental health experts that we use the DSM-5 definition of trauma, which is something threatening to your life or someone close to you, witnessing some sort of life-threatening event where your bodily integrity is harmed in some way. And, you know, you can look up that longer version. But I like to tell providers that there's a practical definition of trauma, which means that trauma is non-consensual. You don't ask for it to happen to you. The victim is in discomfort or feels fear or intimidated, and your bodily integrity or someone close to you is threatened. So then, you know, you can think about a lot of different types of things being traumatic, whether it's natural disasters, car accidents, sexual assault, domestic violence, combat, and various other issues. So I'm not going to belabor the prevalence of trauma in our culture, only to say that it is very high. Child abuse, for example, in large, well-done epidemiological studies, when we survey adults, about 8% of adults talk about being physically abused as a child. About 7 to 27% of women and 8 to 16% of men report a history of childhood sexual abuse. Those numbers are very high. You know, we actually lose a lot of, we lose about 5 children a day to child abuse in our country. Sexual assault and interpersonal violence are also issues, even as adults. Many adult women talk about experiences of adult sexual assault. Interpersonal violence is an issue for women. About a quarter of women in our country talk about experiencing violence by a partner or a former partner. We can see that pregnant women are particularly vulnerable, both psychologically and physically. It's a time that it's very difficult for women to leave an abusive relationship. They feel very vulnerable, often wanting to make a family work, and also it's a difficult time and they're at risk for higher levels of abuse. So I'm going to talk very briefly about the role of physical health and trauma. Okay, there is a very, very well done study that I highly recommend that people look up online. It's called the ACE study, or the Adverse Childhood Experiences Study. And it was a survey of over 17,000 HMO patients, a very large middle-class population. And they defined an adverse childhood experience as recurring emotional abuse, recurrent physical abuse that happened before the age of 18, sexual abuse, neglect, a lack of emotional support in your home, separation or divorce, seeing your mom being beaten, having a family member who was incarcerated or a family member that was mentally ill or abused alcohol. So all of those things count as an ACE, an adverse childhood event. And the take-home point of this study is that adverse childhood events are associated later in life with various negative health outcomes: autoimmune diseases, COPD, frequent headaches, heart disease, liver disease, lung cancer. And when we look at the literature across the board in various types of traumatic events, not just necessarily childhood abuse, but also adult abuse, adult sexual abuse, interpersonal violence, we have a tremendous amount of literature that suggests that traumatic events are associated with negative health outcomes and negative ways of coping, whether it be overeating, smoking, high-risk sexual behavior. So we talk about this a lot more in the archived version of this, but we have a really interesting paradox in the literature. Basically, survivors of traumatic events talk about feeling sicker. Their doctors agree with them. They use medical services at a higher rate. They seem to have poorer health outcomes than people that haven't survived traumatic events. However, survivors of traumatic events are less likely to use preventive health care. So it's kind of this interesting paradox where people are feeling like they're not well, but then they're also not going into their doctor for preventive services. So we have an issue there, and that's particularly true when people have experienced things like sexual assault, domestic violence, combat. Those tend to be the traumatic events that are associated with some of the most negative outcomes. So what is going on? You know, I think that basically this bodes very well for the idea of we need a trauma-informed healthcare system. So what's the definition of trauma-informed care? And this is from the National Center for Trauma-Informed Care, where they suggest that trauma-informed care is where every part of an institution, from the front desk staff to administrators to the care providers who are on the front lines, really understand what traumatic events are about. They interact sensitively with trauma survivors. They avoid re-traumatizing people, and they screen and engage in prevention as appropriate. I've underlined the words as appropriate because often we think that screening is the only thing we can do. And we go into more detail in the archived version of this presentation, but we have proposed that within trauma-informed care in healthcare settings, that you can actually think of it as a pyramid type of framework. And you don't often, screening is actually at the tip of that pyramid, but lower down, there's a lot of things that healthcare providers can do to be able to engage people that have been traumatized effectively in care. So some of those are very basic at the bottom of the pyramid there. We call those patient-centered communication skills or patient-centered medicine. Good communication skills, asking people, what can I do to make you more comfortable? What can I do to help you? Explaining how an appointment is going to flow to decrease people's anxiety. If we move up the pyramid, it's understanding the health effects of trauma. Trauma has health effects, and it influences the way people cope. So just even an understanding on the part of our healthcare providers will go a long way. Collaboration, knowing who are the people in your community that are good, sensitive providers. Providers knowing what their own trauma history is, engaging in good self-care as we move up this pyramid. And then finally, screening as appropriate. And in our archived presentation, you'll find more details about certain screening tools we might suggest. So how does this fit in to the concerns of prenatal care and also postpartum concerns of women? The answer is very consistently. For example, when we ask women who've experienced childhood abuse histories, what are your concerns? Well, they talk about that they're experiencing more abuse during pregnancy. They, in systemic reviews of the literature, it's been found that prenatally, women who've been abused have more medical contacts and more ultrasounds that are that are not scheduled. So again, it fits with that larger picture of higher healthcare usage. Often women talk about feeling re-triggered during exams because, you know, something's happened to your body that was out of control, and now you have to seek medical care and you feel out of control with your body. Postpartum, women talk about a higher level of pain during delivery and also higher rates of postpartum depression. So I think that it's a very consistent picture with the larger literature and really, you know, makes us more committed to the fact that our healthcare system needs to be trauma-informed. So thank you very much.
Next, we'll hear from Dr. Sheridan Phelan on tobacco use counseling.
Good morning. It should not be surprising to this audience that smoking cessation efforts were strongly advocated in the ACA. Reasons such, oh, this is very sensitive, there. Reasons, 25% of deaths in the United States can be attributed to smoking consequences. It's interesting that women are so worried about breast cancer, and yet lung cancer kills more of them, and the #1 killer of women is heart disease. And you can see the contributions that cigarette smoking makes to those. In pregnancy, it is particularly important because it is directly related to about 25% of the preventable causes of poor birth outcomes, including small for gestational age, preterm deliveries, abruptions, and other placental pathologies. Nicotine is quite addictive. There's no two ways around it. That's part of the reason why women, despite knowing, or individuals knowing that smoking is not something you should do, about 25% or more of our population do smoke. It can be due to the availability of tobacco products in their community that encourages smoking or promote, or at least does not discourage it. You start smoking, you get the nicotine in your body, and the nicotine through neurotransmitters creates sensations of well-being, enhanced performance, other kinds of senses, feelings of just improved or control over things. These are very powerful sensations which then reinforce continued smoking. People genetically, societally, and so forth may be predispositioned to be more likely to become addicted or less so. But this is what you're dealing with the smoking continued use. Now, pregnancy is a great opportunity to try to change behavior, and that's one reason we're having this webinar. Women are very motivated to do what's right by their infant, or I should say their fetus. It's kind of interesting, once the baby's born, much of this motivation disappears. But during pregnancy, they get much more support. People at the workplace will say, oh, you're not supposed to be smoking, let me not smoke around you, all of these types of things. And it's not socially accepted, so there's a lot of peer pressure. These all give us an opportunity to intervene at a time where the woman may be best able to break this habit. One problem we're confronted with, and I want to bring up, are some of the alternative tobacco products now. E-cigarettes are the most common, and they are being promoted, as it says here, a better smoking choice. Make the switch today and live healthier. They're advertised as safer, yet they are still, in most cases, delivering nicotine. You can get juice or the solution that does not contain nicotine, but most folks use the nicotine containing. And nicotine is a great part of the problem of smoking. Granted, you are avoiding the combustion or the smoke, but that does not make them safer. I advocate that we refer to them as potentially less harmful. Different emphasis. Now, it has been shown that with a simple intervention, you can make changes. Many physicians or healthcare providers had avoided asking about cigarette smoking because they didn't know what to do. Now I want to share with you a couple of the interventions that have been proven to help. And the most common one is the 5 A's advocated by the National Cancer Institute. The first one is to ask. Simple enough. But don't do it as, you don't smoke, do you? Because you'll probably get the answer you want, which is no, but not the truth. They advocate instead giving the patient either a card or in the questionnaire or verbally asking her a series of options, which give her the permission to be a smoker and go from there, all the way to non-smoking. This gives you a more accurate intervention or assessment. After that, advise or educate. Healthcare providers are pretty good about that. We say, no, best thing to do is not to smoke. It's dangerous for your baby. But we tend not to make those very personalized. We'll assess, are you interested in quitting? But when it comes to the assist and arrange, most of us fall down in that area. And so for that reason, a new model is often encouraged in this time of limited time within the prenatal visit. So we're asking the provider to ask about tobacco use, advise about the need to quit, and then refer. And you need to work up your referral source. Will it be 1-800-QUIT? Will it be someone in your office who is a strong advocate for smoking cessation, your hospital program, but refer. And then follow up each visit. How are you doing? What can I do to help? Now, one of the things providers will be often asked to help with is any pharmaceutical interventions. It is clear in the non-pregnant woman or individual that pharmaceutical assistance really makes a big difference along with counseling in smoking cessation. This data is not as clear in pregnancy, but should be considered and explored. The common ones are nicotine replacement, bupropion or Wellbutrin, and Chantix for the non-pregnant individual. In pregnancy, as I said, the efficacy of these are a little less clear and the safety is a little less clear. Nicotine replacement are category C, except for the inhaled and patch, which are Ds. Hence, remember the electronic cigarette, that's inhaled nicotine. That is a D product. It's also reasonable to use pharmaceutical methods during breastfeeding, particularly the nicotine replacement. Again, there is some concern about bupropion, but I would, in light of the whole issue of worrying about trauma and trauma being a source of the use of cigarette or continued use of cigarettes, consider a antidepressant if part of the reason the woman is continuing to use cigarettes or is in the process of relapsing, that we add that to our approach to helping her succeed. Postpartum is the other issue. About 50% of women who are smoking will quit, either spontaneously or with help during pregnancy. Unfortunately, about 50% of them relapse during the postpartum period. How much of that is the lack of support from their peers, societal restrictions against smoking, and how much of it is in response to postpartum depression and the stresses of a new baby, going back to work, I don't really know. One of the things is the OB provider often is unable to give them as much support as they were during pregnancy, and so I would advocate that we consider enlisting our pediatric providers to help us keep track of these women because they're often able to see them much more frequently during newborn care. And then my last point would be I would encourage you to become an advocate for smoking cessation or behavioral change for your patients, either through supporting people in your office to do it or you yourself. Not only helping the individual patient with the 5 A's or the 2 A's and the refer, but educating the public, speaking to women's groups, and so forth. Become a tobacco control champion. You can make a difference. Thank you.
Thank you, Dr. Phelan. Next, we'll hear from Dr. Loafman on alcohol misuse screening and behavioral counseling. Dr. Loafman.
Thank you, Dr. Landau. It's great to be here. It's such an important topic, and I'm proud to be part of this team and look at what we really feel like is an opportunity to frame a new approach to prevention and improving maternal-child health outcomes. I liked Dean Martin's charge to us to help improve outcomes knowing the data that we have. So really there is an opportunity here. The health outcomes and prevalence of alcohol effects on patients and women and children in childbearing age the evidence is so well known now. We know that there's an opportunity to do something about it. The harm that's caused is prevalent enough that it's a sort of a public health issue that's before us. The common nature of it, the common use of alcohol in our culture, we'll talk about that briefly. And so many of the disorders that we screen for in pregnancy are not preventable. We try to find them to manage them. This issue is entirely preventable, which really from a public health point of view piques our interest and should put us right on the forefront. And behavioral health issues are increasingly seen as within the scope of primary care. So one of the things I find as a primary care physician most exciting is this more holistic, integrated approach. And team care around that's very important as well. So all these things are coming together at a time when we realize we can make a difference. Based on all of that, the recommendation now for alcohol use in any perinatal population is for universal screening. And as Dr. Phelan said about tobacco, we no longer want to just ask, you don't drink, do you? And if the answer is yes, you need to quit or cut down. That sort of approach is very outdated. If it worked, we wouldn't have the problems that we have. So the recommendation is for a better type of screening. To do that, we need to overcome the barriers that we know are there and build on what works. And we do have models that work, and the SBIRT approach we'll talk about in just a second to get a little more information about that. So fetal alcohol spectrum disorders and fetal alcohol syndrome, very well known, well described. It's a predictable impact. Alcohol's toxic to infants and fetuses, and it certainly complicates the perinatal period, both from preconception all the way through. So harm to pregnancies has been documented all the way from the preconception period. And so again, you have an environmental exposure, this toxin alcohol, which from a socio-culture perspective is normalized to be around and to use. So it's this kind of oxymoron of a situation of alcohol use being normalized, in some ways glamorized, and misuse being trivialized in our culture at a time when we also know now that that's a toxic effect. So take out the cultural acceptance of alcohol and just think about the substance as toxic. We would obviously avoid it in pregnancy at all times. Reproductive age women, about 1 in 2 use alcohol. Not surprising, knowing how prevalent alcohol use. Of those, about 1 in 7 report binge drinking, and for women that's 4 to 6 drinks at a time. That level is known to cause irreversible harm to a fetus. Because of the timing of pregnancy and the rate of unplanned pregnancies and not knowing the time it takes to know, about 1 in 20 pregnancies were exposed to excessive, clearly toxic levels of alcohol. So we look at the frequency of that, again, before women know they're pregnant or confront the need to change alcohol use in pregnancy. Already 1 in 20 have had that impact. So again, from a public health point of view, this is a big deal, and it does need our attention. The U.S. Preventive Services Task Force has looked at this and has given it a B recommendation. And what that means is the screening works, behavioral interventions work, and that there's no evidence of harm. So you have something that's prevalent, we have a screening tool that works, we have interventions that are helpful and without harm, so that's a no-brainer that we're going to move ahead on that. Dr. Phelan talked a little bit about the 5 A's. She mentioned some of the complications with the time it takes to do it, but we know these steps are really very important to assess, advise, agree, assist, and then arrange. And if you think about it, this is not new. This is what we do for genetic screening and counseling, for an abnormal ultrasound finding, for any other problem that shows up in pregnancy. This is exactly what we do. So we're advocating not a new model, but to just do for alcohol and other behavioral issues exactly what we already do for other problems. We take a little bit more active role. We don't just wag our finger and say, an abnormal genetic screen, you need to find somebody to take care of that for us. No, we assist, we advise, we arrange, so that's the goal. Screening options, there's a lot out there. The top 4 we've listed here are the ones that have been approved and recognized for use in pregnancy. So those are the ones we recommend. The audit tool at the top is what the U.S. Preventive Services Task Force recommends. So it's a great place to start. The audit tool is there. The TACE and the TWEAK studies or tools have also been validated in pregnancy, and they're out there. The T and TACE and TWEAK really speak to the need to look at tolerance. And so what we've learned is when women are answering questions about tolerance, it's a little less clear that we're screening for problems. It just sort of identifies the fact that people have had a history of alcohol use to the point they've built up tolerance, which is kind of a big red flag for the volume of alcohol that patient may be consuming. So those are particularly helpful. And then the 4 Ps, again, it's just an approach looking at alcohol use in the current pregnancy and then alcohol use around the patient. So these are all models that work. I've highlighted the ACOG antepartum record that many of us use in our practices for prenatal screening. There are 3 questions in there about alcohol use. Our history of getting that right and having it be effective is not very good. So again, I think the key is that this is such an important issue, use what the evidence supports. It doesn't mean we don't use the ACOG tool, but it may not be effective by itself. And then there's some pre-screening that you can do. The Audit C is 3 questions. It takes less than a minute to do. It's very sensitive and specific. It's been validated in pregnancy. And the NIAAA, the National Institute of Alcohol Abuse and Alcoholism, has a one-time question. That's helpful. So the timing for screening is not an issue. There are other tools you're aware of, CAGE, DAST, again, but a little bit less evidence in pregnancy, and so we try to pick tools that we know are validated and useful. The audit, this is just an example of the Audit C. It shows you 3 questions. It gets really at all these tools. What they get at is what's the pattern of use? How often do you drink? How much do you drink on a regular basis? And is there problem drinking or misuse drinking? One thing we want to keep in mind in pregnancy in the perinatal population, we really have 2 aspects of screening that we're going after. Preconception, postpartum period, we're looking at misuse, overuse. Abstinence is not required in that environment. But in the pregnant patient or in someone who's not actively trying to avoid pregnancy, who could become pregnant, there really is no safe dose. And I think it's a culture shift to get at abstinence of alcohol in that population. Again, knowing that it's a toxic substance for fetuses, there's really no safe dose. So it would be the only reasonable approach would be abstinence. So we're kind of having this dance we have to do between looking for misuse and problem use in most populations, but an abstinence of use in the perinatal population. Brief intervention in opportunistic setting, it's really shorter and most cost effective. So again, the point of this is that just screening by itself only helps if we have something we can do for a positive screen. And as Dr. Phelan pointed out about tobacco, it's certainly true for alcohol. We don't want the answer to be yes if we're going to get caught, not knowing what to do or interrupting the workflow in our busy clinic and that sort of thing. So brief intervention is the way to go. It builds on the existing therapeutic relationship we have with our patients. It need to have a focused message. It needs to be flexible. It's a structured process, but it's going to be flexible just like we do with any other patient advocacy and counseling. It builds on this model of integrated care. Brief intervention is a single quick thing, only helps a tiny bit. It has a little tiny impact, but what does help is repeated over time. So coming at it again and again, no different than we do for any other behavioral change related healthcare. So treating alcohol misuse just like we do everything else is what works. So that's what brief interventions are. It's the common approach that we talk about. So again, the reason we harp on this a little bit is that screening by itself is not enough. You need to be able to go ahead and do the next step. So the brief intervention and referral to treatment. Most women will not need referral to an alcohol or addiction specialty program, but those who do, you want to have that smooth, clear handoff, just like we would if it was a genetic disorder, an abnormal ultrasound finding, or a significant medical disorder. We want to have that smooth handoff to make that work. And lastly, these are what works about effective brief intervention, is that stay objective. It doesn't help to argue with our patients. We want to focus on evidence and information and health and safety, the positive high road, not about bad behaviors. We're going to use open-ended questions. We're going to listen. We're going to be empathic, as we always are with other conditions. And we're going to give patients choices and bring them in as a partner, and also follow up in our coaching role. So the very few patients who need to be referred out will be done so, but most in this process can be managed in primary care. So screen and do brief intervention is very, very helpful. Thank you.
Thank you, Dr. Loafman. Next, we'll hear from Dr. Menard on screening for depression. Dr. Menard.
Good morning. I think by now you're beginning to see themes of behaviors that can certainly impact neonatal and maternal health. Underlying change of behavior, though, is an emotional set point or a state of mind. And I've had the privilege of talking with you for a brief amount of time about screening for depression, screening and treatment that can potentially, if effective, impact our ability to influence these health behaviors. About 10% of adult women meet criteria for depression in this country, and 80% of those individuals with depression will report some level of functional impairment related to that. We're left with, and this will contribute to home life problems as well as work life, and it's estimated that that depression is the second leading cause of disability for women worldwide. Moving particularly to postpartum depression, which I think gets the most attention in the perinatal period, but of course isn't, the postpartum period isn't the only time that we need to attend to this during pregnancy. But postpartum depression affects about 22% of postpartum women. It's newly diagnosed within 3 months postpartum in the major depression level in 6.5% and in a minor depressive symptoms in 14.5%. These rates are comparable to women who aren't pregnant, and the impact on their quality of life is similar, but it has particular impact in the peripartum period in that we're impacting the life of a woman, the life of a family, and certainly the life of the newborn. The risk of maternal mortality through suicide and infant mortality comes through neglect, abuse, and sadly homicide. Infants display delayed psychosocial, cognitive, neurologic, and motor development when they're cared for by women who are experiencing depression. And these disorders, thankfully, improve when the maternal depression is in remission. How frequently are we providing preventive services in this arena? A 2012 study of the diagnosis of treatment of depression in the U.S. Demonstrated that about 66% of non-pregnant women and 59% of pregnant women were experiencing depression. That only roughly 1/3 of those women sought treatment with a mental health disorder, with a mental health professional. Survey research, recent survey research suggests that about 10% of OBGYN physicians, recent graduates, report routinely screening for depression. So our challenge is to give you some kind of tips as to how to do this in your practice and do it in an efficient and effective manner. What are the best practices? There are a number of different methods out there for screening for depression, but there really isn't any strong evidence to recommend one method over the other. So clinicians can choose the method that's most consistent with their patient population and their practice setting. And there really isn't sufficient evidence to say this is when you have to do it in the prenatal period, in the on the immediate postpartum period, 6 weeks postpartum, timing and such. Not strong evidence to really prescribe one particular screening time, but nonetheless, the American Academy of Pediatrics recommends screening mothers for depression at the 1, 2, 4, and 6 month well-child visit, partnering with OBGYNs in management of this important condition. ACOG states that screening for depression has the potential to benefit a woman and her family, and should be strongly considered in pregnancy and postpartum period. Examples of screening tools, I mentioned there are numerous out there. The Edinburgh Postnatal Depression Scale is a popular one, which is a 10-question a questionnaire that has depending on population, a wide range of sensitivity reported, but as high as 100% sensitive in some studies, and as high as 100% specific in some populations. A patient health questionnaire comes in a 2 and a 9 question format. Beck depression is also well described and available for review, and all of these are available in English and Spanish and validated in various countries and populations and throughout the perinatal period. Perhaps the easiest, quickest way to implement this is to use the patient health questionnaire, which is 2 simple questions. The first question being, over the past 2 weeks, have you felt down, depressed, or hopeless? And over the past 2 weeks, have you felt little interest or pleasure in doing things? If the responses are positive, then giving a more detailed set of questions and even diagnostic evaluation would be indicated. What we've become accustomed to using and have implemented effectively into our practice where I work at the University of North Carolina is the Edinburgh Depression score. And it helps. It's a 10 as I mentioned, it's a 10-question self-administered questionnaire that we give to patients, and our nurses are instructed to introduce it to women so that it's more acceptable with a phrase such as this: pregnancy and birth experience brings out a lot of different emotions. I'd like to know how you're feeling. And basically introduce it in a very soft way to give women permission to answer the questions honestly. The questionnaire is available online, as I said, 10 questions, and the women, and there are questions about emotions, and then each question has a scale of 3 different points. If it's not an issue at all, it's a 0. If it's a concern, as high as 3. And then this is scored. And if the score on the 10-question survey is greater than 12, this is a concern. This is a concerning rate that would warrant a referral for counseling with or without medication. The alarm, if there are alarming responses that have to do with self-harm or suicide, of course, that needs immediate referral in an emergency situation. Intermediate answers would warrant close follow-up and counseling, and a negative screen or a lower score would be just counseling about the condition itself, but encouraging follow-up if there are any concerns, but it helps us triage. Transitioning from a positive screen to more effective analysis and treatment, phrases like this might help. Your questionnaire indicates there might be some concern, then we delve into the past history, we delve into the current emotional state, and decide where to go from there. Embedding health professionals, tips for treatment, embedding health professionals within the obstetric office is very effective to help women accept further counseling and treatment. This multi-component treatment program where the obstetrician or the OB provider shares responsibility with a familiar mental health worker works very, very well. Psychotherapy, medication, rest, exercise are all very well evidenced resources that can help. And there are a number of medications that are safe, but citrulline is considered the preferred antidepressant during breastfeeding because of transmission into the breast milk. Barriers to screening are prevalent just in these other services. Provider awareness is important. The stigma or willingness to disclose is a concern. Time, providers' comfort with managing the problems. Resources for follow-up. Resources for follow-up are particularly key and important to develop within health systems. Reimbursement for services is now available, and codes for this help with that. In conclusion, it is recommended that screening for depression in adults, when resources are available to ensure appropriate diagnosis and therapy, current evidence for women in the postpartum period is consistent with the recommendations and well accepted. Thank you.
Thank you, Dr. Menard. Next, we'll hear from Dr. Zink. Did I advance the slide right? Whoop. Who will talk about intimate partner violence screening. Dr. Zink.
So intimate partner violence, also referred to as domestic violence, we think of physical abuse, sexual abuse, emotional abuse, and also what's called social control. And that means controlling what an individual can do, who they can talk to. So we can thank sorry about this. There we go. We can thank the media for reminding us that intimate partner violence is a problem in our society. So 20 years ago, it was O.J. Simpson. the concern of murdering his then wife, and more recently we're hearing a lot about members of the NFL. So this is a problem that affects all members of society. 1 out of 3 or 1 out of 4 women, 1 out of 10 men. In men, it is often, there's a power differential, so it's really more common in women, and that's the focus of this talk. So we know intimate partner violence also affects pregnancy outcomes. It causes problems during pregnancy and causes problems with the baby, such as preterm weight and underbirth. We also have, it's taken us a while to understand that it's important to do this. These are hard studies to do, and in the last 10 years, the evidence has improved, and we can say that there is benefit to the women and not harm in asking about intimate partner violence. So let me tell you a story. In the late 80s, a patient I'll call Grace came to see me for ear pain. I looked in her ear and I saw that her eardrum was ruptured, and I asked her what happened. And she said her boyfriend had done that to her. And on more questioning, this had been an abusive relationship for a while. She was fed up with it. She was ready to get out of it. And I had noticed on the bulletin board in the doctor's room that there was a flyer with the local advocacy agency. So I called that agency, put Grace on the phone. She was in touch with them and got out. And that was really the end of my involvement with that story. Now, the reality is intimate partner violence is rarely that easy. So I think of it really as a process of managing and helping anyone with some kind of chronic health issue, many of those that we've talked about so far. It's a process of building trust and helping a patient understand that how they are being treated is not appropriate in a relationship. And when we talk about trauma approach care, often patients have been victims or watched their mother be a victim. And so it's helping people learn what really is the normal in society. So how do we ask? So it's important that the patient be alone, that we do not ask in front of the partner, that we ask in a caring and non-judgmental manner, that I think it's easiest to talk about this when we talk about social history and social supports. Do you work outside the home? Who lives in your home with you? What's that relationship like? Is it a supportive relationship? What happens when you fight? We can talk about different ways for different screening tools that are available. So it is important to listen for clues. The person who doesn't make eye contact with you, you may have a partner in the room who's particularly kind of the helicopter partner. And it's important to use an interpreter. Family members should not translate for this conversation. So a number of ways of screening have been tested. There's pros and cons to all of them. The most recent studies suggest that a written screen may be the preferred, although studies come to different conclusions. So I think the important thing is to look at your setting. It may be a setting that lends itself to a computer screen. It may be a setting that lends itself to paper and pencil, or it may be best to ask. So it's imperative to ask when there's an injury. And if a patient gives you an explanation that doesn't make sense for the injury you're seeing, it's a good idea to ask, again in a non-judgmental way, if that really happened. But if you push too hard, you're going to lose the patient, because there's often quite a bit of shame that accompanies intimate partner violence. It's important to ask when you have the unexplained stresses and complaints, the fatigue, the trouble sleeping, any kind of chronic health problem, chronic headaches, pelvic pain, abdominal pain. It's always important to ask about safety in a relationship. Any kind of mental health diagnosis, and again, important to watch for clues. The patient who has a lot of discomfort with a pelvic exam, for example. So I've come to think about intimate partner violence much as I do any kind of behavior change that we're trying to help patients with. So the Prochaska-DiClemente model, the stages of change, as providers, I think that we are often helping patients in the pre-contemplation and contemplation stage, helping them understand what is appropriate in a relationship and what is not, and if it's not a supportive relationship, how are they going to manage that? Leaving may be the option that they need to pursue, but not necessarily. It's often much more complicated than that. So I think our role as providers is really to ask. My goal is not necessarily to get the positive answer, but to ask and assess the patient's situation and their safety. So when I get a positive screen or an equivocal, then it's important to validate. Thanks for telling me that. I know this is hard to talk about. No one deserves to be hurt. That, you know, what you tell me is between you and me. If I'm going to start documenting with codes in the chart, and we'll talk about that later, it's important to negotiate that with the patient. It's important to know your resources, and so in your practice, know who the advocacy agency is in your town, or if you work in a larger system and have access to a social worker, make sure that that social worker or your mental health providers are comfortable with working with victims of violence. So there are, you can see the website on the bottom there. There's a number of tools and resources to help you do this effectively. You don't need to recreate the wheel. So there are times that I worry, and I worry when there are weapons in the home, if there are thoughts of homicide or suicide, if there's excessive substance use, drugs or alcohol, either the part of the patient or her partner, and if there are escalating threats. If the children are being hurt, and half of intimate partner violence also have homes where child abuse is going on, if there's harm to the pets, and if the patient really expresses fear of her partner. So there is a danger assessment tool that you can use. You don't necessarily need to do this yourself. You may put your patient on the phone with your local advocacy agency or do a handoff within the clinic as well. But it's important to know when you need to be concerned. So when is it necessary to report? About 5 states in the U.S. at my last check are mandatory reporting states that says if you ask about intimate partner violence and get a positive screen, you need to report that to authorities. This is quite controversial. Some people believe that it really helps to make the individual safer. Others believe it puts them more at risk if the resources really are not there to support them and come through. So in Ohio, we are a non-mandatory reporting state. It's not necessary to call the police unless a weapon is used, a gun or knife, and if there are severe burns. So if I'm going to call the police, that's something I negotiate with a patient. One of the most important things as a provider is appropriate documentation, and we're familiar with the SOAP format. It's important to use the patient's words in the subjective part and to document what we see. If there are broken bones, to take x-rays, to use a body map or a camera and do the appropriate documentation for photographs, and your protocols tell you how to do that. So good documentation helps to prevent you from going to court to testify yourself, should a legal solution be sought. So in summary, I think the asking women is imperative, and that it's really a process of developing a relationship, a trusting relationship with a patient in order to help them understand whether or not this is a safe and supportive relationship, and then to link them to resources. So we know simply handing people a paper is not enough. A warm handoff is preferred. So if you're in a setting where you have a social worker, to introduce them to the social worker, or as I discussed, to connect them on the phone. So it is much easier to call a phone number when you've already talked to the voice on the other side. So their confidentiality is important, particularly in our world of caller ID, so it's important to negotiate that with the patient. And finally, There's a number of screening supports and guidance as far as coding goes. So in summary, the important thing is ask and be aware of what your supports are for the patient.
Thank you, Dr. Zink. Next, we'll hear from Dr. Phipps on screening and management of obesity in pregnancy.
Thank you very much. Privileged to be here today. I am going to just go over a couple of disclosures. I am a member of the U.S. Preventive Services Task Force and also a member of the ACOG Committee for Underserved Women. I don't have any financial disclosures, but around my disclosure with the U.S. Preventive Services Task Force is that this presentation represents my own views and not the views of the task force and should not be attributed to the task force. So let's move on to the issue of obesity in the United States. This is a map of the United States. You might recognize that. And this is, shows us that the issue of obesity is growing and very much a national problem. For the majority of states, there's over 20% of the populations are obese. And within that, the majority are actually 30% are obese. And that means they have a body mass index of 30 or greater. This issue extends into pregnancy because approximately 30 to 50% of women who present for prenatal care are obese or overweight. That's a very large portion of pregnant women. So that's why we're talking about that today. What can we do? The issue of working with women prior to pregnancy would be ideal, to get women to an ideal weight prior to getting pregnant. However, the reality is that women come and see us when they're pregnant and are obese. So it is our job as providers to think about how we can optimize their pregnancy outcomes through counseling and screening. So as we think about this, we need to help women understand and help all of us understand the risks that have been associated with obesity in pregnancy. And there are maternal risks, as you can see here, from gestational diabetes, preeclampsia, risks associated with delivery, cesarean delivery, as well as postpartum weight retention. There's also issues related to the fetus. We have prematurity, stillbirth, congenital anomalies, macrosomia, and childhood obesity. So these are significant problems, as I know you can relate to. When we think about this and we start to think about what can we do to help women who have obesity while they're pregnant, we start with the very first prenatal visit. We assess them by determining their body mass index. Then we need to formulate a plan about good nutrition and weight management during pregnancy, as well as physical activity and exercise. This also involves ongoing management during prenatal care. It's not just an initial visit issue. This is an ongoing issue during pregnancy. We need to monitor their weight gain, discuss their diet and physical activity, as well as giving feedback, understanding barriers to achieving their goals, and then giving guidance about preventing excessive weight gain. So how do we do this? We start with body mass index, as I described before. Most of our electronic medical records actually have a tool built in to help us calculate body mass index. But if that's not the case, there are many tools online. This one happens to be from NHLBI and the NIH.gov. That is a tool where you can enter the patient's height in feet and inches and their weight in pounds, and it calculates their BMI. From there, you can go to the IOM recommendations, Institute of Medicine, where it has guidance based on a pregnant woman's BMI, how much weight she should gain during pregnancy. And we're going to concentrate on that obese range right now, which is a BMI of 30 or greater, with a recommendation to gain 11 to 20 pounds during pregnancy. That is not a lot of weight gain. So that's why this is a really critical issue, to be able to communicate and effectively partner with the patient. We have part of that is nutrition, as we talked about, diet. A lot of our community resources, we do have nutrition or WIC resources in the community, but we also need to be informed to help a patient understand what her goals are and how she can achieve them during pregnancy. So we think about in the first trimester, a patient who has a BMI of 30, she might not need to have any additional caloric intake during that first trimester. It's really more in the second and third trimester where she would increase her caloric intake, but really not by that much, 250 calories a day. And then we want to counsel on how she can achieve that, and it's really around a well-rounded diet. And then having her understand the foods to avoid, which are high sugar, high fat, low nutritional value. The other part is exercise or physical activity. And that's maybe part where we drop off a little bit, really understanding where they're starting from. What is their current level? Is it sedentary or is it active? What could we realistically have as goals for exercise during pregnancy? What are the barriers? It's wintertime, whatever it might be, really thinking about what is accessible to her in her community. What are the resources within her own support system, her partner, her friends, her family? Can they get engaged with her to increase activity? And then are there resources in the community, whether it's a YMCA or some other type of activity that she could be involved in? Knowing those resources is critically important to her success. So let's just apply this to a person, a little vignette here. 24-year-old woman comes to see you for prenatal care. It's her first pregnancy. She had her first positive pregnancy test, or hopefully her only positive pregnancy test, 2 weeks ago. And she wants to focus on what she can do to have a healthy pregnancy. You assess what her weight was before she got pregnant. She says 155 pounds. And then you do an exam and you don't have any really other concerns about her. So you go to your trusty BMI calculator and you put in her height, which is 5 feet 0 inches, and her weight, which is 155 pounds. You see that her BMI is 30, so that puts her into the obesity range. So you go to your IOM, to your IOM calculator, and that tells you, or the graph, and you see that her pregnancy weight gain goal is 11 to 20 pounds. So your counseling for her should be around her goal for weight gain, which I just don't give them the range of 11 to 20 pounds. I usually say we are shooting for a weight gain of 20 pounds or less during this pregnancy, which is a difficult conversation. And that we're really centering that around the weight gain in her second and third trimester, which would be about ½ a pound a week, which means you need to talk about the calorie counts that are associated with that. So we're talking about, in the second and third trimester, about 250 calories extra per day. I'm sorry, it says per week, but it's per day, so that her weight gain would be 0.5 pounds per week. Again, talk about good nutrition. And then her exercise goal. This patient was sedentary, so we're really talking about walking, which is a perfectly healthy activity for a pregnant woman, and that our goal is around 150 minutes per week, and she can break that up however she'd like. Then we also want to talk about how she keeps track of it to help her get motivated and help you review it with her during her prenatal course so you can figure out barriers and encouragement. So it's really important about keeping track. The other part, I'm sorry, my fingers trigger happy here, that we have online resources, which a very helpful one for many pregnant women is actually the choosemyplate.gov, and it has pregnancy-specific recommendations. Women can use it to figure out what is nutrition. This is often a new conversation for people during pregnancy to understand what calorie counts are and how they can manage it. Just outside of pregnancy, once she's postpartum, you can follow the U.S. Preventive Services Task Force and should the recommendations around obesity in adults. And that is essentially anyone with a BMI over 30, everyone should be screened, a BMI over 30 should be referred to or given counseling that includes multi-component behavioral intervention. And this includes lifestyle modification, which is critical. So to wrap this up, We need to assess for BMI at the first prenatal visit and then formulate a plan with the patient that includes the Institute of Medicine recommendations. We want to discuss the risks associated with excessive weight gain so the patient understands why you're having this conversation, and then review the weight gain goals at that visit, but also subsequent visits so that she will monitor that herself and with you. And then postpartum, you want to follow the U.S. Preventive Services Task Force recommendations with lifestyle modification and interventions. And then one of the components is to encourage breastfeeding, which I know is our next speaker. Thank you so much.
Thank you, Dr. Phipps. So you've already introduced the next topic. Dr. Borders will be speaking to us about interventions to promote breastfeeding. Dr. Borders.
I'm so happy to be here in Ohio to talk with you about breastfeeding. This is an issue that has become really in the national spotlight. It is one of the few interventions we have that improves health outcomes for both moms and babies and is readily available and very inexpensive. So we know that the breastfeeding has been covered by the ACA. I just want to briefly mention it's not just our services as providers that are covered, but also supplies breast pumps for our patients who are going back to work. It's important that your patients are aware. The reason it's covered by the ACA is because it's such an important part of healthy moms and babies. So why does this matter for providers? Lots of providers have had limited education about breastfeeding, about counseling for breastfeeding, and about the evidence-based support that we want to give women during pregnancy and after they deliver to improve breastfeeding outcomes. Many physicians think it's someone else's job, or certainly not something I want to talk about, or maybe just touch on briefly. And I think the most important thing we can take away from today is that breastfeeding is everyone's responsibility and that what we say to our patients makes a difference. Breastfeeding is certainly a public health issue. Even in developed countries, infants who are not breastfed face higher rates of infections, chronic diseases, and mothers who do not breastfeed face higher risks of cancer and metabolic disease. And the other thing that's very, very important in terms of the evidence is that it's very clear that what physicians say matters. Both randomized and other trials have shown us that what physicians say to their patients makes a huge difference in a patient's decision to breastfeed and then how long they continue to breastfeed. Our goal is not to tell every woman that she should breastfeed. Our goal as providers is to make sure that we're educating all of our patients about the benefits of breastfeeding and that we're providing the evidence-based practices to make sure that they can reach their breastfeeding goals. It's incredibly important that patients hear this information from us because they listen, even when we don't think they're listening to us. I wanted you very briefly to see some of the evidence because I think this matters to physicians and providers. We really need to take to heart that breastfeeding is an incredibly important intervention to help us improve health outcomes for moms and babies. I want to make sure you understand it's both moms and babies who benefit, whether it's breast cancer reduction, ovarian cancer reduction, diabetes, hypertension for moms, infections for babies, but also reducing SIDS, reducing asthma, reducing childhood leukemia, and reducing childhood obesity. The other thing that's incredibly important is around preterm infants, understanding the increased outcomes and improved outcomes with breastfeeding. So what can we do? We're not going to have time today in our 10 minutes to go through all of this, so I really want to refer you to the longer talk. But very briefly, there's very clear evidence that we need to follow evidence-based practices in our hospitals. Many hospitals across the country are implementing baby-friendly initiatives. You don't have to implement all 10 steps. You need to be on the pathway and thinking about what you can do as a provider to be a leader in helping make sure that your hospital is implementing evidence-based practices to support our moms. Breastfeeding peer counselors is an incredibly important tool, particularly for our most at-risk populations. We need to educate our moms, and that's where our role as providers comes in play. We're talking to our patients, and we need to be talking to them about breastfeeding. Support in the workplace, and then professional support. So this is about the evidence-based breastfeeding support, and this is really understanding the 10 steps that are recommended. This is the baby-friendly initiative recommended by the WHO. A lot of hospitals across the country are working on becoming baby-friendly. It makes sense for patients and it makes sense for hospitals. But even if your hospital isn't on the baby-friendly pathway, I really recommend that you take a look at this and think about if you have breastfeeding protocols on your labor and deliveries, because this is where the evidence is pointing us, and we need to be right there behind it. So what is our role in all of this? As providers, again, the most important thing we can do is educate and talk to our patients. Again, this does not take a lot of time. This is really about saying, what do you know about breastfeeding, rather than saying breast or bottle. Breast or bottle is, the 1970s, 1980s way of talking about breastfeeding. Today, we need to ask our patients what they know about breastfeeding and address their concerns and tailor our recommendations. We also need to make sure they understand the recommendation from ACOG and the AAP for 6 months of exclusive breastfeeding with continuation for 1 year or longer as mutually desired by mother and infant. What I tell my patients, that any amount of breast milk is better than none, and that the more breast milk a baby has is better than less. And that, I think, is less intimidating. We want to make sure they understand the recommendations, but we also want them to empower them to set their own breastfeeding goals. We want to encourage prenatal breastfeeding classes. So again, what do you know about breastfeeding? Address their issues and refer them to a prenatal breastfeeding class. You don't have to be a breastfeeding expert to do a great job at counseling women on breastfeeding. We want to review all drugs and medications that the patient's taking. An incredibly important tool is LactMed. I encourage all of you before you leave today to take out your iPhones or other devices and download the LactMed app on your phone, and then you'll have it in your pocket. It's a great resource and probably the best tool we have to look at medications and pregnancy and medications and breastfeeding. And remember that the placenta and the breast are not the same, and it's really important that drugs during pregnancy are not the same as what we're looking at for lactation. So look it up on LactMed. We want to, when we move to labor and delivery, ensure that our labor and delivery nursing staff are working to provide 30 minutes of skin-to-skin for every term healthy newborn. We want to ensure that we're working on getting breastfeeding going in the first hour on labor and delivery if we can, the golden hour. And we want to make sure we have protocols in labor and delivery to help this be a health systems-based approach, not just does it happen or not, but how do we make sure it happens for all moms. We want to make sure that for all moms separated from their infants, particularly our premature babies heading to the NICU, we want to promote breast milk. And so we really want to ask those moms, will you pump milk for your baby? Your baby's milk is medicine. They need to make sure that they understand it's a really important intervention for improving the outcomes for preterm babies. And the other important part of that is not, you've had a hard time, go sleep for the next 24 hours, we'll talk about pumping tomorrow or the next day. We want moms to start pumping within the first 6 hours. It's really important in terms of the physiology of milk production that they start pumping within 6 hours of delivery. And this is something we need to work on with our neonatology colleagues and make a plan on labor and delivery. We promote rooming in, nursing on demand, and exclusive breastfeeding post-delivery in the hospital as a key to increasing milk production and therefore duration of breastfeeding. These are all the evidence-based practices. Finally, when you send moms home, give them a number, make sure they know who to call so that they can be successful with breastfeeding. So just to summarize, during your antenatal care, you want to ask moms, what have you heard about breastfeeding? And you want to tailor the concerns. You want to make sure they understand the guidelines. You want to refer them to classes. You review their meds. And don't give out any formula gift packs. For preterm deliveries, and remember, mother's milk is medicine. When preterm delivery is anticipated, ask them, will you be willing to pump breast milk? Counsel mothers, they only may produce a few drops in the first few days, and make sure that they are supported. For deliveries at term, again, you want to be talking about it on labor and delivery. What's your plans for breastfeeding? What do you know about breastfeeding? And then postpartum, how is breastfeeding going? We need to be supporting our moms. Breastfeeding can be hard, and we want to make sure that they feel supported and they feel that we're here to help them. What I often say, how is breastfeeding going? Who can we get in here to help you? You don't, as a provider, have to be the expert. If you know how to do holds and you know how to do the latch, that's wonderful, but you don't have to in order to be a really important part of the breastfeeding support team. You need to know how to engage your nurses and lactation consultants. You need to know who that person can be referred to when she's sent home and that she has a phone number she can call. And you need to make sure that your office staff and patients are calling in that first week. that they know how to triage a woman with breastfeeding concerns. And when you're sending a woman home postpartum and you're giving her precautions, you are telling her, please call for your breastfeeding questions. We want you to be successful. We want you to reach your breastfeeding goals. So in summary, breastfeeding improves short and long-term health outcomes for both mom and baby. It's really important that we put this in our heads. Remember all the things we do to try to have healthier moms and babies, that this is one intervention that really works. We have so few that really do. Breastfeeding has become a national public health priority, and it's because it's an important intervention. Remember that what we say matters. Many studies have shown that the physician is the #1 person who makes a difference in a woman deciding to breastfeed, along with encouraging her family to be educated about it as well. Remember that we need to provide evidence-based breastfeeding support across the spectrum, prenatally, on labor and delivery, and postpartum in the NICU. They're evidence-based practices, and if your hospital hasn't implemented them in a systematic way, I encourage you to go back and be a leader and an advocate for helping look at those protocols and go to Baby Friendly USA and figure out what those protocols are. Finally, you can make a significant health difference for your patients, both moms and babies, by promoting and supporting breastfeeding. It's important that we all take a moment and think about what we can do for healthier moms and babies, and certainly thinking about breastfeeding and talking about breastfeeding in a positive way is something you can do. Thank you.
Thank you, Dr. Borders. Well, I warned you that this was going to be a fast-paced, information-packed session, and I think we delivered on that promise. I'm confident that these presentations have stimulated thought on how you can best provide these screenings, counselings, and referrals in your practice, but we know we only had time to scratch the surface. As we've mentioned earlier, in order to provide greater detail on these issues, we've recorded each of these presenters discussing their topics in much greater depth. The extended presentations, clinical vignettes, and the clinical implementation guide will be available online within the next week. We'll be communicating with you via email to provide the URL to access these presentations and the other resources described. We will also offer continuing education for viewing these online presentations. I want to thank our hosts, Dean William Martin in the Ohio State University, our presenters, Dr. Sheila Raja, Dr. Sharon Phelan, thank you, Dr. Sharon Phelan, Dr. Mark Loafman, Dr. Kate Menard, Dr. Therese Zink, Dr. Maureen Phipps, and Dr. Ann Borders. Let's give them all one more round of applause. I'd also like to thank my staff, Michelle Hirsch, Leslie Craig, Badisha Sinha, Latanya Stanberry, and our interns, Meredith Anderson, Heidi Ortolaza Alviar, and Almay Wee, and SAMHSA Regional Administrator Dr. Jeff Cody for his help. And please also join me in thanking, oh, well, yeah, right. Please also join me in thanking the AV staff who have done such a wonderful job for us today. Thank you. Finally, thanks to everyone who took their time to participate today in person and via the webcast. We certainly hope you found this useful, and I urge you to consider integrating what you've learned into your practice. Please be sure to complete your evaluations, and once again, thank you for being here today and for your dedication to improving the care you provide to your patients. Be well.